Hello, I'm Dr. Naeem, and welcome to my channel MedWise by Dr. Naeem. Today, we're diving into mastitis, a common and painful condition affecting women. I'll cover its types, anatomy, causes, symptoms, diagnosis, how it differs from breast cancer, standard treatments, home remedies, why females are affected, and how age plays a role. Let's get started. What is mastitis? Mastitis is an inflammation of the breast tissue, often involving infection, causing pain, swelling, and fever. It primarily affects women during lactation, puerperal mastitis, but can occur in non-breastfeeding women, non-puerperal mastitis. It's prevalent due to breastfeeding practices and limited rural healthcare access. In the UK, 10% of breastfeeding women develop mastitis, and prompt treatment prevents complications like abscesses. Types of mastitis: puerperal, lactational, mastitis, occurs during breastfeeding, typically within the first 3 months postpartum, due to milk stasis or bacterial infection, Staphylococcus aureus. Non-puerperal mastitis affects non-breastfeeding women, caused by ductal ectasia, chronic infections, or trauma. Includes periductal mastitis, around milk ducts, or granulomatous mastitis, rare, autoimmune. Breast abscess, a complication of untreated mastitis, forming a pus-filled cavity requiring drainage. Anatomy and physiology: mastitis affects the breast's complex structure. Anatomy: the breast consists of glandular tissue, lobules producing milk, ducts, transporting milk to the nipple, and fatty tissue. Lactiferous ducts converge at the nipple, where milk exits during breastfeeding. Blood vessels and lymphatics supply the breast, with axillary lymph nodes draining infection. The areola contains sebaceous glands, prone to bacterial entry if cracked. Physiology: during lactation, prolactin stimulates milk production, and oxytocin triggers milk ejection. Milk stasis, blocked ducts, creates a medium for bacterial growth, leading to infections. S. aureus enters via nipple cracks or poor hygiene, causing inflammation or abscesses. Non-puerperal mastitis involves chronic ductal inflammation or autoimmune responses. Causes: etiology: mastitis results from infectious or non-infectious factors. Puerperal mastitis: milk stasis, incomplete breast emptying due to infrequent feeding, poor latch, or tight clothing. Bacterial infection: S. aureus, most common, Streptococcus, or E. coli enter via cracked nipples or infant's mouth. Risk factors: first-time mothers, stress, fatigue, or oversupply of milk. On puerperal mastitis, ductal ectasia, blocked ducts cause inflammation, common in perimenopausal women. Trauma, injury, piercings, or surgery introduce bacteria. Chronic conditions: diabetes, smoking, or autoimmune diseases, for example, granulomatous mastitis. Cultural factors: poor breastfeeding education, unhygienic practices, and delayed treatment in rural areas. Shorter breastfeeding duration reduces incidence, but stress and formula supplementation increase risk. Age-specific causes: young women, 20 to 35, puerperal mastitis during childbearing years. Middle-aged, 35 to 50, non-puerperal mastitis, often periductal or granulomatous. Elderly, greater than 50, rare. Linked to chronic infections or malignancies mimicking mastitis. Signs and symptoms: mastitis symptoms develop rapidly, affecting one or both breasts. Common symptoms: breast pain, tenderness, or warmth, swelling, redness, or a firm, wedge-shaped area. Fever, greater than 38 degrees Celsius, chills, and fatigue. Flu-like symptoms: body aches, headache. Puerperal mastitis: engorgement, blocked duct sensation, or reduced milk flow. Nipple pain or discharge, occasionally purulent. Non-puerperal mastitis: chronic pain, nipple retraction, or peau d'orange skin, in severe cases. Abscess, painful, fluctuant mass with possible pus discharge. Age variations: young mothers, acute, lactation-related symptoms. Older women, subacute, with persistent lumps or skin changes. Note: persistent lumps or atypical symptoms require evaluation to rule out breast cancer. How to diagnose mastitis: diagnosis combines clinical evaluation and tests, clinical assessment history, recent childbirth, breastfeeding challenges, nipple trauma, or chronic breast issues. Physical exam: inspect for redness, swelling, warmth, or masses, check lymph nodes for enlargement. Laboratory tests: milk culture, identifies S. aureus and locational mastitis, guiding antibiotic choice. Blood tests: elevated white cell counts, or C-reactive protein indicates infection. Imaging ultrasound detects abscesses or fluid collections, differentiates mastitis from malignancy. Mammography, used in non-puerperal cases for women greater than 40 to exclude cancer. Biopsy for granulomatous mastitis or suspicious lumps to rule out malignancy. Challenges in Pakistan: limited access to ultrasound delays abscess detection. Overdiagnosis of mastitis may miss inflammatory breast cancer. Urgent action: fever and breast symptoms persisting greater than 48 hours despite treatment need medical review. Differential diagnosis with breast cancer: distinguishing mastitis from breast cancer, particularly inflammatory breast cancer, IBC, is critical. Mastitis presentation: acute onset, fever, flu-like symptoms, and breastfeeding history, puerperal. Redness and warmth are localized. Response: improves with antibiotics within 48 to 72 hours, milk culture often positive. Imaging: ultrasound shows inflammation or abscess, no malignant features. Age: common in younger women, 20 to 35, during lactation. Breast cancer, including IBC, presentation: subacute or chronic, no fever, unless advanced, and no breastfeeding link. IBC causes diffuse redness, peau d'orange skin, and rapid breast enlargement without a discrete mass. Response: no improvement with antibiotics, persistent or worsening symptoms. Imaging: mammography or ultrasound may show masses, microcalcifications, or skin thickening. Biopsy confirms malignancy. Age: more common in women greater than 40, though younger women can be affected. Key differences: mastitis is infectious or inflammatory, resolving with treatment. Breast cancer is neoplastic and progressive. Lymph node enlargement in mastitis is reactive and soft. In cancer, it's often hard and fixed. IBC mimics mastitis but lacks systemic symptoms like fever and has rapid progression. Diagnostic approach: if symptoms persist greater than 1 to 2 weeks or there's no breastfeeding history, order imaging, mammography/ultrasound, and consider biopsy. Limited awareness delays cancer diagnosis. Warning: non-resolving breast lumps, skin changes, or nipple retraction require specialist evaluation to exclude malignancy. Most affected gender: mastitis exclusively affects females due to breast anatomy and physiology. Why females' breast tissue, ducts, and lactation predispose women to milk stasis and bacterial entry. Hormonal changes, for example, postpartum prolactin surge, increase susceptibility. Risk factors: lactational mastitis, breastfeeding mothers, especially premiparous women, due to inexperience. Non-puerperal mastitis, perimenopausal women, smokers, or those with diabetes. Pregnancy/postpartum, Pakistani women face higher risks due to prolonged breastfeeding and poor hygiene in rural areas. Cultural barriers: in both UK and Pakistan, stigma may delay seeking care. Education is crucial for women, particularly UK-based South Asian communities. Mastitis and age: mastitis varies by age group. Young women, 20 to 35, puerperal mastitis dominates, linked to childbirth and breastfeeding. 20% of breastfeeding mothers are affected. Middle-aged, 35 to 50, non-puerperal mastitis, often periductal or granulomatous, due to ductal changes or chronic infections. Elderly, greater than 50, rare, but chronic mastitis or abscesses may occur, often mimicking malignancy. Global data: WHO notes high mastitis burden in low-resource settings like Pakistan due to poor maternal health care. In the UK, early intervention reduces complications. Prevention through breastfeeding education is key across ages. Treatment for mastitis focuses on relieving symptoms and resolving infection using standard medical and surgical approaches. Medical treatments: antibiotics, Staphylococcus aureus coverage, flucloxacillin, 500 mg 4 times daily, 7 to 14 days, or erythromycin, for penicillin allergic patients. Severe cases: intravenous flucloxacillin or clindamycin if oral therapy is insufficient. Analgesics: paracetamol or ibuprofen to manage pain and fever. Continued breastfeeding: encouraged to clear milk stasis and promote drainage, unless an abscess is present. Supportive measures: hydration and rest to support recovery. Surgical treatments: abscess drainage, ultrasound guided aspiration, minimally invasive, or incision and drainage under local or general anesthesia for larger abscesses. Biopsy, performed in cases of non-resolving granulomatous mastitis to rule out malignancy, especially in older women. Supportive care: warm compresses applied to the breast to reduce pain and improve milk flow. Breastfeeding support from lactation consultants, community health workers to correct latch and feeding techniques. In early antibiotic therapy and breastfeeding continuation, access to timely care can be challenging, underscoring the need for education. Home remedies. These natural remedies support treatment and prevention. Tailored warm compress. Apply to the affected breast for 10 to 15 minutes before feeding to relieve pain and improve milk flow. Cabbage leaves. Place chilled cabbage leaves inside the bra for 20 minutes, 2 to 3 times daily, to reduce swelling. Turmeric paste. Mix 1 teaspoon turmeric with water and apply to the breast to reduce inflammation, as in my fatty liver video. Garlic. Consume 1 to 2 cloves daily in curries to boost immunity, as in my stroke video. Hydration. Drink 2 to 3 liters of water daily to support milk production and recovery. Gentle breast massage. Massage the breast during feeding to clear blocked ducts. Fenugreek seeds. Soak 1 teaspoon in water overnight and drink to enhance milk flow. Common in DESI households. Rest and stress reduction. Prioritize sleep and relaxation to aid healing. Caution. Continue breastfeeding and consult a doctor if symptoms persist beyond 48 hours or worsen, as this may indicate an abscess or another condition like breast cancer. Mastitis can be a distressing condition for women, but with early diagnosis, differentiation from breast cancer using imaging and biopsy, standard treatments like antibiotics and abscess drainage, and home remedies such as warm compresses and fenugreek, relief is possible. If you found this video helpful, don't forget to like, subscribe, and share for more medical insights on MedWise by Dr. Naeem. Comment below, what's your breastfeeding tip? Stay